Yeah, something like that.
Said that.
Yes, that was one. Oh, you are. There were a couple of those.
It is a small world. That's what happened when I was on the board of directors for Southern.
Pass on that. Yes.
Please. So I have like a. So I guess. So. There's something about the bubbles when you pull it out.
European allergy insurance.
Well,
Where's that help?
Yeah, I kind of when I made it, there were no bubbles. And then when I sent it down,
okay. Friend of Mason's getting married.
Before we start,
I'm like Issa Westlake.
What? Yeah. It's like, really?
What happened? He stinks.
Yeah.
Might as well just like walk in. Treating you guys pretty well. Where are you now?
so trying to get to
There was an over. Is that you?
when is granddaughter?
What you're meant to be.
First birthday is right. You're 7 years old. Just something like that.
Yeah.
That's right.
Look at these. And we'll have we'll ask your interpretation.
So that was my mistake. All right, let's go ahead and get started. I asked Jamie to do this topic because I've always found this sort of a nebulous area. We all pretty much know the protocol and good testing methods for penicillin. Good literature, obviously, going back a long ways, and reasonably good cephalosporins, different classes of cephalosporins. But for the most part, how we test for other classes of antibiotics, as far as I can tell, is we just make it up. And don't have very good established standards. I know you guys here at the U do some testing that we don't actually do in practice. I don't know if you just made up the protocol. Just made them up. So Jamie will give us the scoop on what's really true about how to work up other classes of history of antibiotic reactions.
So, yeah, I wanted to focus on skin testing and looking at what is the literature behind the utility of doing skin testing for antibiotics other than penicillin and cephalosporins. So, like, no disclosures. So, the antibiotics that I'm going to focus on are macrolides, fluoroquinolones, vancomycin, and sulfa. I'm going to go in this order throughout my talk. So, macrolide hypersensitivity reactions are fairly rare, and it's not entirely clear what the cross-reactivity is, but it has not been commonly reported. So these are the chemical structures of some of the common macrolides, and you can see that azithromycin and erythromycin look fairly similar to each other compared to erythromycin. And so looking at this, you may speculate that there's more cross-reactivity between azithromycin and erythromycin than erythromycin, just based on what the structures look like. So the first article I'm going to discuss was titled Diagnostic Value of Oral Challenge Testing in the Diagnosis of Macrolide Hypersensitivity. This study was done in Turkey, and for the studies that I'm going to go through today, I'm going to point out where they're from because you're going to see that most of them were not done in the U.S. And so that may limit some of the generalizability to our population. So this was done from an adult allergy clinic in Istanbul. There were 25 patients with a history of reaction to macrolides, and then they took 20 controls without a history of macrolide reactions. They classified the reactions as early, within 1 hour of taking the drug, or delayed greater than 1 hour of taking the drug.
Wait, go back for a minute here. The nature of the reaction, those are exclusion criteria.
Yeah. So, some of the studies that I'm going to go through today described what the history of reactions were, and some of the studies did not. Some of them just said hypersensitivity reactions and didn't go into more detail. So if there was more information, I included it here. So they did skin prick testing and then intradermal testing, and then in the patients who had a history of delayed reaction, they also did patch tests, and then they did a late reading of the skin prick and intradermal testing as well. And they tested to clarithromycin, spheromycin, azithromycin, and erythromycin, and then they only did the intradermal testing to clarithromycin. I put little stars next to spheromycin and erythromycin. That's because they're not available in the U.S., so they may not sound familiar. And then they underwent drug challenge after the skin testing. So for all the studies as well that I'm going to go through, I'm going to mention what the concentrations were for the skin prick or intradermal, because you'll see that a lot of these studies are not using the same concentrations. Is that also limits how well you compare, each study to each other. And the second table here is the history of the reactions that they had reported. So you can see that clarithromycin was by far the most common culprit drug in this study, and most of the reactions were immediate. A few were delayed, about 15%, and then most of them were urticaria or urticarian angioedema, and then there were a couple anaphylaxis in there as well.
Jamie, doesn't it surprise you that all the patients were women?
Yes. And a lot of these studies actually didn't even mention the whether the breakdown of gender and things like that. So it is. And then most of the studies had a table sort of similar to this one, which is fairly complicated, but you can see that there's, I didn't include the controls in this, but there's all the way on the far left is the patients, the culprit drug that they reacted to, what the reaction history was, and then what they tested to. And so you can see the 4 different drugs here. ST is the skin testing, DPT is the oral challenge. And if you look at the bottom, the key, so NP is not performed. So they didn't do oral challenges to everyone. And so for example, if you look at patient 1, the culprit drug was clarithromycin. They had anaphylaxis to it by history. The skin test was negative, but they didn't do an oral challenge. And again, this is going to be sort of a common theme through most of the articles I go through today, is that they frequently did not do an oral challenge to the culprit drug. And then WT.
But they did do an oral challenge to 3 other drugs in that person?
Yeah, so they did an oral challenge to azithromycin, spheromycin, and erythromycin, but not the clarithromycin that the patient had reportedly reacted to in the past. And WT is well tolerated, NT is not tolerated, so that's a positive oral challenge, just so you guys can see here. Just looking at this table, you can see that, so NT is not tolerated here. There's a group of people who had negative skin testing, and they still failed the oral challenge. And here's a couple people who had positive skin tests that they didn't challenge to. So just looking at this, you can see that there aren't a whole lot of positives either. I mean, there are a couple positives, here and there in the skin testing, but most of these are by far negative. It's not that common to have positive skin testing. So a total of 2.7% of all the skin tests were positive. None of the patch tests were positive. skin testing to the culprit drug was only positive in 2 out of the 25 patients. And they said that 14 out of the 21 negative skin testing had positive oral challenge. So that's a huge number. Out of the controls, 3 out of 20 patients had a positive skin test, but all passed the oral challenge. And if we break it down by macrolide history, so out of the 20 patients who had a history of reacting to clarithromycin, 2 had a positive skin test. Neither underwent an oral challenge to clarithromycin, but all passed oral challenges to the other macrolides. 1 had a positive skin test to zithromycin, but passed the oral challenge to zithromycin, and failed the oral challenge to clarithromycin with a negative skin test to clarithromycin. So looking at that, it doesn't seem like it's that helpful. Azithromycin, there were 2 patients. None of them had a positive skin test. Neither underwent an oral challenge to zithro, but all passed challenges to other macrolides. The 2 patients who reacted to spiromycin in the past, neither had a positive skin test to spiromycin and didn't undergo a challenge to that one. 1 had a positive skin test to clarithromycin, but tolerated the challenge to chlorothro. And the 1 patient who had a history of reacting to direthromycin had negative skin testing, but failed the oral challenge. So looking at those numbers, it doesn't seem like there's...
Doesn't make any sense.
Jamie, did they talk about, like, before they actually presented all this data, did they test for more of a spectrum of strength with the skin test? Because obviously the sensitivity is awful.
Yeah, so you mean the concentration?
Right.
No, not before they did that.
It's kind of surprising because assuming there was no prior data, they wouldn't have tested several strengths.
Yeah, so there are a couple studies I'm going to go through that did, but on the whole, usually they just said they picked a concentration, and it wasn't clear exactly why they sort of decided that concentration.
Yeah.
So.
I'm curious. Yeah.
And when they failed the oral challenges, what was the definition of the failure, and did it replicate their symptoms before testing?
Most of the studies did not say what, they just said failed oral challenge, sort of like that table. And so, you're sort of presuming that they were sort of true, failures like what we would do in our clinic, but it's hard to, that's speculation. Most of the studies didn't mention it, so.
Did they say if they're graded challenges or single blind, double blind?
Yeah, so this one, they were single-blind, placebo-controlled oral challenges. Most of them were graded challenges. Yeah. So they calculated the sensitivity and specificity, and here you can see it's pretty poor. Sensitivity is 0%. And I put this caveat here, and in all the studies, which is most of them today that I'm talking about, had this problem, and not all patients underwent an oral challenge, especially the culprit drug. So it's really hard to interpret the skin testing if you're not even challenging them to the medication that they reportedly had a history to begin with. So
the question is, how did they calculate the sensitivity? Is based on oral challenge or based on the history?
I'm assuming this one it was based on the oral challenge. Some of the studies you'll see I'll go through didn't calculate sensitivity specificity, and I calculated it based on the skin testing and the oral challenges that they reported.
Okay.
So,
One more question.
Yeah.
They didn't include clindamycin in the macrolides, and our computer program keeps flagging everybody's got a history of allergy to a macrolide with clindamycin, and they didn't even address that.
But it's not macrolides.
But it triggers with Epic system that as soon as you're allergic to a macrolide, it triggers clindamycin, which I never knew they were related until our computer keeps telling me over and over this person's allergic. So
yeah,
But it's just like gentamicin.
Right.
Yeah, it's,
It is.
yeah, I don't think
I think
it's
this is
macrolides,
an
so
epic
I don't know
medicine.
why.
I thought it was
Maybe this,
That's the
I don't know,
lysine
maybe
part
the
of it.
chemical structures are similar. I'm not sure, yeah. But I didn't see anything about clindamycin in any of the macrolide
Okay.
studies that I did.
I didn't think they were related, except for my computer keeps telling me that they are. So.
Yeah, I don't know about that, and I didn't see anything in the studies about
I don't
clindamycin.
believe any of it, but that's what I'm going to find out.
It would appear the take-home message of that study is that skin testing is useless.
Yes.
I don't think you can make such take-home
So,
message.
do you
It's not
skin
enough.
test here?
No, not to me.
Not
Yeah.
to
I think
these,
we have the ability. I've never tested.
Yeah.
So all you can do is trust the history. So far, that's one conclusion I got from this.
Yeah.
All right.
That's going to be sort of the reoccurring theme today.
All right.
So. So this next study was done in Turkey, and this was just looking at clarithromycin in childhood reactions. So this included 45 children with a history of clarithromycin reaction. This was all patients who had mild symptoms, just cutaneous, no anaphylaxis in here. And then 20 out of the 45, they did skin prick testing, and I included the concentrations of the intradermal testing followed by an oral graded challenge. And then 25 patients just went directly to oral challenge and didn't do the skin testing. So all 9 patients with positive skin testing had a negative oral challenge, and 2 out of 11 patients with a negative skin test had a positive oral challenge. And none of the direct oral challenge patients reacted. This is again this is my calculations. Sensitivity 0%, specificity 50%. So the next study also was just looking at clarithromycin. This one was from Italy, and this was also just children that they were looking at. This was a slightly larger study, so 73 children. All reactions, again, were skin-related, no history of anaphylaxis, and then they included 18 controls who had tolerated clarithromycin in the previous month. They divided the patients by immediate or delayed reactions. Almost a little over 2/3 of them were late, and a little under 1/3 were immediate. And only 64 patients were included in the final results because 9 of them refused oral challenge. So they just didn't include those in the results, those patients. They did skin prick, intradermal, and then oral challenge. So they said that they did 3 different concentrations of intradermal testing. Sorry, it's a little bit fuzzy, but I just want you to look at the bottom here. So here are the 3 different concentrations. With the highest concentration, they didn't test the patients. They only tested the controls. And then with the lowest concentration, they didn't test the control group. They only test the patients. So it's a little hard to compare between the 2 groups. So I only looked at with the results the sort of intermediate concentration because I felt like the other 2 were pretty useless. So none of the patients had positive skin prick testing. Out of the controls, none of them had positive intradermal testing to the 0.5 concentration, and out of the cases, 9 out of the 64 had positive intradermal testing to that concentration. So then they took those 64 patients and did oral challenges with them. 2 out of them had a positive oral challenge. So this means, sorry, it's not that clear, but they failed the oral challenge, and then 62 of them passed the oral challenge. So out of the 62 that passed, then they put all those 62 patients on a 5-day course of clarithromycin, which is a little unusual because usually when we're testing patients in clinic, to penicillins, we don't put them on a 5-day course of amoxicillin and see if they develop a delayed, rash. And the skin testing usually isn't as predictive for those delayed reactions. So it wasn't entirely clear why they did this. But then out of those 62 patients, 2 of them developed a delayed rash and 60 tolerated it. So then, in their sort of discussion, they clumped these 2 groups together, the patients that reacted to the oral challenge and the 2 patients who had the delayed rash, and they said, out of the 4 total patients who reacted, 3 had positive skin tests. And then they calculated sensitivity and specificity based on that. But they didn't actually say which 3 patients had positive skin tests. I think it would make a difference whether they were the 2 who had the positive, immediate oral challenge and 1 of the delayed patients versus 2 out of the delayed patients and 1 out of the, the immediate challenge. And so I'm assuming they did this to increase their sensitivity and specificity, but it's a little hard to interpret without knowing which of those patients actually had the positive skin testing.
So those stars mean that the people in those groups were Jewish?
Yes, it is. So, for conclusion for the macrolides, overall, very limited small studies evaluating the utility, but overall, the sensitivity ranged significantly, as well as the specificity from study to study. There was only one study looking at that I found the cross-reactivity, and the others just looked at the clarithromycin. Cross-reactivity based on that one study appeared uncommon but possible, and skin testing did not appear to be useful for predicting either cross-reactivity or just, react in general.
The reason we understand how to do skin testing of penicillin is that people years ago worked out the chemistry of what happens when you give penicillin, how it breaks down, how it binds to protein, and hence we know that it can make a hapten protein conjugate, and you can make IgE. So here, people just randomly developing procedure. Anybody go back and try and do the chemistry of what happens to these drugs and have a similar understanding whether the idea of skin testing is even logical?
I didn't see any articles discussing that. So moving on to fluoroquinolones. So one concern about testing for skin testing for fluoroquinolones is that it can be a direct mass autogranulator, and so there's a concern about having false positive tests with skin testing. And some studies have been unable to find reproducible, non-irritating concentrations. Some of the literature will say that moxifloxacin is the most common culprit, followed by levaquin and cipro, and then some reports say that moxifloxacin has less cross-reactivity than other quinolones. So we'll see sort of with the studies whether those two things kind of pan out. So here are the chemical structures again of some of the common quinolones. You can see that levaquin and ofloxacin are sort of mirror images of each other flipped, and so you may think that they, based on just looking at this, they may have more cross-reactivity maybe than others. Maybe moxifloxacin looks, slightly different with this ring, but so this first study was entitled "Diagnostic Testing in Suspected Fluoroquinolone Hypersensitivity." This one was for Germany, and they took patients who were referred with a history of hypersensitivity reaction to fluoroquinolones. They divided the patients into immediate and delayed symptoms. It's interesting, they said the immediate was less than 1 hour and delayed greater than 6 hours. I don't know what happened to the patients who had somewhere between 1 and 6 hours. I mean, I don't know if there just weren't any patients in that group or they excluded them. That wasn't clear. So in this study, they actually said that they weren't able to find non-irritating concentrations. They didn't say which concentrations they tried, but they said that they weren't able to find non-irritating concentrations. They didn't even do intradermal testing. They only did skin prick testing and then oral challenge. So there was a total of 100 patients, and then here you can see how they divided them up, the immediate on the left and then delayed on the right. And then they described what the symptoms were. The 34, they say anaphylaxis grade 1. Here at the bottom, I have sort of the key. So grade 1 was actually just cutaneous symptoms. Grade 2 included respiratory symptoms, GI symptoms, dizziness, presyncope, tachycardia, and then grade 3 was hypotension or loss of consciousness.
Wow.
That's a positive.
Yeah.
They found patients with that severe reaction.
And then in the delayed group, most of them were having drug exanthems, but some of them had fixed drug eruptions, and one had a hypersensitivity syndrome, and they didn't really characterize that further. And then at the bottom, you can see the drugs that there were the most common culprits. So cipro by far in both groups was the most common, followed by, in the immediate group, moxi was second, followed by ofloxacin, and then in the delayed group, ofloxacin, levaquin, and moxi were all kind of similar. So out of the 64 patients with immediate reactions, they did, and remember again, this is just the skin prick, this is not intradermal testing in this study. So out of 64 patients, 12 had positive skin prick, and then they excluded half of those patients for the oral challenge. They said 3 were contraindicated, 3 refused, sort of assumed that the contraindicated ones were maybe the ones with, true anaphylaxis or, where they felt were too high risk. And then so 6 patients underwent an oral challenge, half of those failed, half of those passed the oral challenge. 52 patients had a negative skin test out of the 64. 7 of them were excluded from the oral challenge. 4 of them they felt were contraindicated, and 3 refused. And the 45 that were challenged, 42 were negative and 3 were positive. Out of the delayed reactions, there were a total of 37 patients. None of them had positive skin prick testing. All 37 had negative skin prick testing. They didn't do an oral challenge, understandably, with the patients with the fixed drug eruptions, and then they felt 2 more were contraindicated. So 28 were challenged. Out of the 28, 26 were negative and 2 were positive. And you'll note here that they didn't say anything about which drugs they were reacting to. So they mentioned at the beginning, which drugs by history, but they didn't give anything in the results about, were patients more likely to react to, Levaquin or Cipro. They didn't mention that. This is just the total numbers. So that would have been, I guess, nice to know.
Did they follow the patients the same length of time? I mean, these had initial reactions greater than 6 hours, but then how did they do the oral challenges?
That I don't know, yeah. That I don't recall if they were specific enough in describing the oral challenge. Most of these studies just said they did an oral challenge and didn't even describe, the procedure. So in this study, they didn't look at sensitivity and specificity. I calculated it based on the numbers they had. And again, I only included the patients who actually underwent both skin testing and oral challenge. Sensitivity was 50%, specificity 93%. Again, I put this caveat, not all patients underwent oral challenge. Maybe the numbers would be different if they challenged everyone.
Jamie, did they have a plot of literally every patient? What I'm curious about is the sensitivity if you included the ones with respiratory or loss of consciousness.
This study they didn't. All they did was report these that I have here,
Did you try redoing the statistics and including those that were contraindicated to see if that would boost the numbers? You said that the numbers might be different if you assumed it.
Well, I didn't because I don't know if they would have reacted or not. I mean,
but
I would have had to assume that they would have reacted, and I didn't, make that assumption. So I just left those patients out.
Yeah, exactly.
So this next study also was looking at quinolones as well and their cross-reactivity. So this one was done in Istanbul. 54 patients with a history of hypersensitivity reactions, and this was just within 24 hours of taking the drug. They excluded patients with a history of anaphylaxis, so only more mild symptoms. They did skin prick and then intradermal testing to both the corporate drug and then alternative quinolones, and then they did oral challenge as well. This is the breakdown of the reactions by history, so you can see Cipro, again, is the most common, followed by Moxie, and then Levaquin. And this seems to be sort of one consistent thing throughout most of these studies, that Cipro was the most common, followed by Moxie. And you can see the reactions early versus late, so 3/4 of them were early, about 1/4 were late reactions, and then most of them were urticarial. There was 20% that were anaphylaxis, and then some of them, they broke down sort of urticaria and angioedema. So this was the just the concentrations for you guys to have of the skin prick and intradermal testing that they used. So this is breaking them down by history again. So 30 patients had a history of reacting to Cipro. Five of those had a positive skin test. Out of the 5, 4 did not undergo challenge and 1 failed. The one that was challenged. 25 had a negative skin test. Out of that 25, half didn't undergo a challenge. So out of the 13 that did, 9 failed the oral challenge. So even patients with negative skin testing can, it seems, still react to oral challenge. Moxifloxacin, there were 12 patients. 6 of them had a positive skin test to Moxie. None of those 6 underwent an oral challenge. Out of the 6 that had a negative skin test, half of them, again, didn't undergo a challenge. The 3 that did all failed. Levaquin, sort of similar story. So 1 had a positive skin test, did not undergo an oral challenge to Levaquin. 3 had a negative skin test. The 2 that underwent an oral challenge both failed. Ofloxacin, all those patients, the 5 patients had negative skin testing to ofloxacin. 2 did not undergo an oral challenge. The 3 that did, 2 failed. Gemifloxacin, 6 patients by history reacted to that. None of those had a positive skin test. Out of the 6 with negative skin testing, half of them didn't undergo a challenge. Out of the 3 that did, 2 failed. So I didn't mention cross-reactivity because the chart was a little too complicated, but they did sort of list it out. So the highest cross-reactivity was between levaquin and ofloxacin. And if you remember from the very beginning, I had the structures, and levaquin and ofloxacin were sort of flipped images of each other. And so you might have predicted that just based on molecular structures. And the moxifloxacin had the lowest cross-reactivity with other quinolones. But remember, moxifloxacin, people are definitely reacting to it. I mean, it's the second most common culprit drug, so it doesn't mean that people can't react to it. Overall sensitivity, again, pretty poor, 3.6%, specificity, 95%.
3 of the 4 studies so far have been out of Turkey. That's curious. Are they all out of the same institution?
I don't recall. So these next 2 that are from Spain are from the same institution. I don't know about that.
I don't think you said Anchor was a couple of them.
Yeah, so it might have been.
Probably different places.
So this next study was done in Spain.
So far, I get the take-home message that doing skin testing or challenges to these drugs is relatively useless.
But I mean,
We don't have any the second part.
But I mean, the specificity is 95%. This means that you have good negative predictive value. If you test negative, that's good, with a specificity of 95.
Well, in this last one, though, I mean, if they're not
Sorry,
people
positive
who are skin
predictive
test
value.
negative,
No,
failed the challenge.
It's positive. The problem is, so the specificity is better, but that's because most of these patients with positive skin testing aren't undergoing an oral challenge. So the 1 or 2 that they do, maybe they pass, but there's so few patients. I mean, if you look here, so if you go back here, Cipro, 5 had a positive skin test. They only, challenged 1 of them that failed. So that'll give you a good, specificity. 1 out of 1 patient's, almost 100%. The other ones are not challenging to. So I think it is a little bit misleading that the specificity numbers are higher in all of these studies because you're not challenging.
What do you do with quinolone histories here at the U? Do you skin test these people?
Very rarely.
No.
It mainly comes out of the history. I will. If there's a good history of immediate reaction, I'll test them. But I very rarely test for quinolones. We do it.
Doesn't it suggest it's a reaction to a metabolite?
None of the studies sort of speculated, like I said, what the
chemistry
chemistry was. Yeah.
I mean, you'd think that would be the case because our penicillin cephalosporin testing is the exact opposite results. We're seeing very good correlation with symptoms and testing, and this you're seeing sort of random correlation between history and testing.
What do you do at every clinic? Do you
We basically gave up testing for anything other than the penicillins and cephalosporins because we had such bad results. We do it if we're asked to, but that's the only reason we do it.
So this study was done out of Spain, also looking at patients with a history of reactions to quinolones, only included patients with a history of reaction within 24 hours, and they did intradermal testing with Cipro and levaquin. So here are the concentrations that you can see. This study and the next study, because they were both from the same institution, used the same intradermal concentrations, but most other studies use different concentrations. This study, they divided patients by group. So group 1 were patients who had a history of urticaria or anaphylaxis within an hour of taking the drug by history. Group 2 are patients who had a rash between 1 and 24 hours of taking the drug. Group 3 were patients who developed a rash after 24 hours. And group 4 were sort of atypical symptoms, and they described atypical symptoms as just like pruritus without true rash or just isolated GI symptoms, things like that. So out of the group 1, the immediate symptoms, there were a total of 27 patients. 17 had a positive skin test. Out of those 17, 11 were not challenged. The 6 that underwent an oral challenge, 5 reacted. So this study might have had actually the most patients that they actually challenge to, even though they're still excluding a lot of patients that they're not challenging to with positive skin testing. The negative skin tests, half of them did not undergo a challenge. The 5 that did, 4 passed. Group 2, the patients who had a delayed rash between 1 and 24 hours. Total of 8 patients, 3 had positive skin testing. 1 underwent an oral challenge and passed.
Not my fault.
5 had negative skin testing, all 5 passed the oral challenge. Group 3, patients who had a delayed rash after 24 hours. 7 had positive skin testing. 6 out of the 7 didn't undergo a challenge. The 1 that did pass. 17 had negative skin testing. 16 out of the 17 underwent an oral challenge. 1 reacted. 15 passed. And then the atypical symptoms: 4 had positive skin testing. 2 didn't undergo challenge. 2 passed. 8 had negative skin tests, and all 8 passed the oral challenge. So again, I calculated the sensitivity and specificity by groups. And group 1 had a sensitivity 83%, specificity 80%. The other groups I couldn't calculate sensitivity because there weren't any true positives, so I just did specificity. They were 80 to 90%. So again, this is another article from Spain, the same institution as the previous one. This one is interesting because it's entitled Low Cross-Reactivity to Levaquin. And I'll go through that in a minute. This was only 12 patients with history of immediate reaction to fluoroquinolones. They did skin prick testing and then intradermal testing to both Cipro and Levaquin, and then challenged them. Again, this is the same concentrations of the previous study because it was the same institution. So this is their little chart. So it's interesting here. So they include norfloxacin and ofloxacin to the skin test, but NT is not challenged. So they didn't actually challenge any of those patients. And if you look at the patients by history, the culprit, none of them actually even have a history of reacting to norfloxacin or ofloxacin. So I don't know why they even included those in the skin testing. So I kind of just excluded them when I was looking at the results. So if you look at patient 1, just to kind of go through this, so this patient reacted to Levaquin. If you look over at Levaquin, skin testing was negative, NT is not tested. So they weren't tested to Levaquin, but if you look over at Moxie, they had negative skin tests, they still reacted. And so you might think, well, again, they're not challenging patients to the culprit drug regardless of the skin test results. But if you look over at patient 9, that patient had a history of reacting to Cipro, negative skin testing, but had an oral challenge. So even within some of these studies, they're not even, they're testing some patients to oral challenge to the culprit drug and not testing other patients to oral challenge the culprit drug. And it's unclear whether that was, patient preference or the researchers that were making that decision. If you look over at Moxie for the oral challenge, there are a fair number of patients who are reacting to oral challenge for Moxie. And again, remember the title of this study, Low Cross-Reactivity to Levaquin. I'm not sure how to interpret that when there's, 2 patients who are reacting to Levaquin. If you look over at the Cipro, 1 patient who reacted to Cipro, they weren't challenged to Levaquin. If you look at, the 2 other patients who reacted to Cipro tolerated Levaquin. But some of these patients who are reacting, to Moxie, they're not being challenged. So it's like a total of 3 or 4 patients. I mean, it's hard to make any conclusion about cross-reactivity, looking at this. So if we look again by culprit drug, so 5 patients had a history of reacting to Levaquin by history. 2 had positive skin testing. None of them underwent an oral challenge. 3 had negative skin testing. The 1 that underwent an oral challenge failed. Cipro, none had positive skin tests. The 5 out of 5 who had negative skin testing. 2 that underwent an oral challenge failed. Sort of a reoccurring theme here. Moxie, similar story, except for the 2 that had negative skin testing actually passed for Moxie. And then if we look just by skin testing, so this doesn't have to do with the culprit drug, just did they have a skin test and did they have an oral challenge. So 12 patients were skin tested to Levaquin, 2 had positive skin testing, none of those underwent an oral challenge, 10 had a negative skin test. Out of those 10 that were skin test negative to Levaquin, 2 didn't undergo an oral challenge. Out of the 8 that did, 6 passed and 2 failed. Cipro, a total of 10 patients were skin tested. All 12 had negative skin testing. A quarter of them didn't undergo a challenge, and the ones that were challenged, 2/3 of them passed and 1/3 of them failed. Moxifloxacin, a total of 10 patients. The 2 that had positive skin tests failed an oral challenge to Moxie. Again, why they decided to challenge those patients with the positive skin testing and the other ones with positive skin testing they didn't challenge to is not clear. 10 had negative skin testing. Out of the ones that were challenged, half of them passed, half of them failed. Overall, 2 out of 12 patients had a positive skin test of the culprit drug, and both were to Levaquin, but neither underwent oral challenge to Levaquin. Again, I calculated sensitivity and specificity, again, with this caveat. So sensitivity, 20%, specificity, 100%. Again, that's only because 100% is they only challenged 2 patients that had positive skin testing, and they both reacted, but they didn't challenge a bunch of others that had positive skin tests. So.
Did they say why they didn't challenge them?
Well, but I mean, you have to assume that some of them, they were worried that they were too high risk, that it was the culprit drug, skin test was positive, they were afraid they were going to, react, but then there was one patient who they did challenge the culprit drug, so I don't know.
Jamie, what we ought to do, every year we have John Lynch from ID come and give us a superb presentation, and since, to me, the take-home lift of this is our approach to evaluating allergy to these drugs is pretty much useless, other than the history. We ought to find out how the ID service handles this, because I don't know what happens within the university hospital. Do they contact Allergy when they have problems? You guys called by the ID service to work up these patients, or they just handle it on their own and just accept the history?
We get a lot of consults on the inpatient side, and they will send us patients. But
and then
the majority they deal with themselves, but the more complex ones they do send us, and mainly for the history going through each of these. But we do skin testing with some of them. No, but it'd be interesting to ask John about that.
Yeah, because he's involved in antibiotic stewardship and obviously deeply involved in proper use of antibiotics, and this must come up all the time. And it strikes me we don't have any solution for them, but remember to ask him when he's a speaker.
So I promise I'm almost done with the quinolones. So this last one is going to be short and quick. So this one is entitled, so the only good thing I think about this article was the title, Moxifloxacin Hypersensitivity, Uselessness of Skin Testing. So this one was out of Belgium. There's 14 patients with history of immediate reaction to Moxi. This one actually said that they did include patients with history of anaphylaxis, but they didn't say how many patients had anaphylaxis. 16 controls who had tolerated an oral graded challenge to Moxi. They did skin prick and then intradermal testing. Now I put here in bold, none of the patients they actually did an oral challenge to. So they only did intradermal testing. So then they calculated sensitivity and specificity and the positive and negative predictive value. How can you do that if you're not challenging any of the patients? I mean, they obviously just use the history, but as we know, just because someone has a history of reacting to a drug doesn't mean that if you give it to them in the future, they're going to react again. So I would sort of ignore the sensitivity and specificity of this study. All of the patients and controls had negative skin prick testing. And then I think the only takeaway from this study was that most of the patients, regardless of whether they were patients or controls, had positive intradermal testing. I think the only thing it tells me is that those were irritating concentrations. So I think we've sort of talked about the conclusions. Skin testing does not appear to be helpful. Sensitivity and specificity vary significantly from study to study, and most studies didn't even perform oral challenges to all the quinolones, and especially to the culprit drug, and so it's really hard to interpret cross-reactivity or to interpret these studies, Anyways. Moving on to vancomycin, it's going to be much shorter. There was, for all the studies that were out there about fluoroquinolones and macrolides, there was much less information about vancomycin. I found very few studies. I found one case report that I'm going to go through where skin testing appeared to be helpful, and then I found a study looking at whether skin testing to vancomycin is useful for predicting the severity of red man syndrome symptoms. So I'm going to go through those two. But as we all know, vancomycin has been known to be a direct mass autogranulator and can cause non-IgE-mediated reactions that can be severe and can be difficult to differentiate from true anaphylaxis. And so the QADI practice parameters actually say that skin testing with a non-irritating concentration should be considered to help differentiate these sort of red man syndrome symptoms from true IgE-mediated reaction. So this really was the only case report that I found. It was a 60-year-old woman who had Enterobacter bacteremia and had a pacemaker infection, so she had her pacemaker removed. She was on antibiotics, gentamicin and ampicillin for 2 months, and then she developed a hematoma at the site of her prior pacemaker site, and so she needed surgical drainage for that, and that's when she got vancomycin. So this is just sort of a timeline of the procedure. So at 7:45 in the morning, the area was cleaned with chlorhexidine, and she was given a dose of preoperative vancomycin. About 20 minutes later, she was given propofol and succinylcholine. About 10 minutes after that, she developed hypotension, flushed in, difficulty to ventilate. They treated her for anaphylaxis with epi, steroids, albuterol, Benadryl, and they checked the tryptase level during the episode, which was markedly elevated 69, implying that this might have been a true, IgE-mediated reaction. So 6 weeks later, she came back and underwent skin testing to everything that she had been exposed to, including a couple of the neuromuscular blocking agents. And the only thing that she was positive to was the vancomycin on skin prick testing with a 10-millimeter wheel. And she had negative skin testing to everything else. And then they said that they performed the same skin testing to vancomycin on 10 controls that were all negative, sort of implying that this wasn't just an irritating concentration. Although I think it's hard to start, testing all patients of vanc based on one case report. This implies that maybe it was helpful in this specific case. And then this next study looked at skin testing with vancomycin and whether it was useful for predicting red man syndrome symptoms. I'll point out this is a very old article. This is from 1993. So this, they took 11 healthy men without a history of previous drug reaction. They did skin prick testing followed by intradermal testing to vancomycin. And then after the skin testing, they brought them back a week later and gave them a infusion of vancomycin. This is sort of a standard dose of vancomycin. And then they said that wheal and flare occurred in all subjects with the higher vancomycin intradermal concentrations, but no reactions to the lowest concentration of vancomycin intradermally. The wheal was relatively constant with the vancomycin intradermal doses, but the flare increased in a dose-dependent manner. With the infusions, they said all subjects experienced red man syndrome with erythema. 10 out of 11 patients had pruritus, and they said 5 out of 11 had hypotension, which sort of struck me as surprising. I mean, a lot of patients get, red man syndrome symptoms. I wouldn't say all patients, but certainly not, half of patients who are giving vanc become hypotensive. But I looked back, and they described hypotension as a fall of like 9 millimeters of mercury in the systolic, and diastolic like less than 70. I mean, if your blood pressure is going from 160 to 150, it doesn't mean you're hypotensive. So I don't know if those patients were truly hypotensive or they just had very low criteria for that. So, but regardless, they said that there was no correlation between any measure of the skin testing, either the wheal or the flare, and the symptoms that they had to the infusion. So for vancomycin, very little information out there. Again, I didn't find any larger studies looking at sensitivity and specificity, positive predictive value for vancomycin, just that one case report, and then the other study. And, that one other study showed that there's no evidence for at least skin testing for predicting severity of red man syndrome symptoms. But, again, just not very much information. So sulfa is the shortest and sweetest because So I couldn't find any studies looking at skin testing for sulfa reactions. I couldn't find any case reports. So there's really nothing to go through. Questions?
Sulfa causes so many reactions. I'm surprised you couldn't find any literature of people trying to evaluate it.
Yeah, so I didn't look at patch tests, so I don't know if there might be information out there. I was just looking at skin prick and intradermal testing. I couldn't find any doing like a PubMed search. So
there's a notorious absence of Tim Sullivan and Rebecca Gershall in all this data. So have they not done any studies on these drugs? Because they were the sort of the state of the art for the other drugs. Now, nothing from them.
I don't know. I was just doing like PubMed searches and seeing what I could find, and these are the ones that I found.
I remember that too from about 30 years ago, and it just like disappeared.
Yeah, no,
Tim moved to
Tim
Florida.
Sullivan?
Yeah, and Rebecca Gershall. There's nothing. Lately from either of them. So my summary, and before Lynn says it, is that if you're going to do any of these drugs, you should just desensitize them and not bother trying to test any of these people.
Well, I think taking a history and then I don't know that they all. I mean, you know, depending on the history. I mean, graded challenge seems like it could also be appropriate. I think the other thing to take away is that you can't necessarily, cross-reactivity seems also, difficult based on history. Some patients, there's clearly some cross-reactivity between these classes, but it's hard to predict. Skin testing doesn't seem to be useful for that either. So you may just have to pick another within the class and do a graded challenge to a different, within each class of drugs as well.
I suspect what the ID people do is they just move to a totally different class of, antimicrobial and don't deal with the problem.
Right.
If you look at this data, that might be the best answer.
Yeah. You'd be on shaky grounds if you had a patient that was negative on, because so many patients were negative on testing but had positive history and still did not pass the oral challenge. You'd be on shaky grounds to prescribe that drug for a patient.
Yeah, I think that you would have to do a challenging clinic. I don't think just sending them away and saying because the skin testing was negative. Clearly, patients are reacting with negative skin testing.
When they did the oral challenges, you had the late reactive group, but did the oral challenges follow those people out for 24, 48 hours, or just 1 hour, and then it was negative at 1 hour?
I don't know. Most of the studies didn't specify that.
Do they even adequately define a positive challenge, what the nature of the reaction was? So, that's, just trusting...
I was surprised by how many patients with negative skin testing still reacted, and so I did wonder whether they were not, maybe they were sort of atypical symptoms, pruritus, who knows what they categorized a positive oral challenge to.
Thank you for your insight.
Sensitivity, right? You can't go high
Well, I
enough.
didn't know, going into what I'd find.
And testing times per mil. Everybody would be positive. Yeah, including the positive.
Pretty good, kids.
Do we need like a world control they're all in different places.
Yeah, well, it's
I've been loving this.
Yeah. Ghost. How's Wendy?
Oh, by the views. Oh, no.
Maybe I check Epic and don't listen to the Epic cross reactions between Clindamycin and Macrolide because
There are.
Google says it doesn't. It's not.
Oh,
So I don't know why our Epic is triggering that. Mike looked it up for me and showed me there's no.
just want to bring out every time I try and write this
Super when you're going to, because they had a reaction.
but it's
They need to make them up to say they're well controlled. It'd be nice if they would require appendices that
is that right?
data for each.
Okay.
I know you that maybe doesn't know a lot of people in this area. I know they're already on the Cairo
I mean, everybody's.
I mean, like I said, they're already on the
Is your volume might be the same as it used to be?
The volume's okay, the problem is.
What's it up to?
Well, it's artificially abnormal right now because we had a big argument with Mira about our growth.
Sorry, so sorry.
Going back about calculate what we're really receiving. But the best that's artificial, but even at the best scenario, we're about 6. Yeah. You can think about just taking home 30 cents on the dollar. It's not a savable situation.
What I've noticed is
I honestly think that the young faculty are better off than the young people
they're not really
going to practice. The
a
university
lot of people will
Right.
stand there
Retirement plan and all that.
retirement and benefits, so
will you
even
sign
if you
in
take home
and
income.
they will know everybody.
And I know what the room makes and I know what the
I would just need like 6. Exactly.
Not
Exactly.
everybody
And
wants
so,
to be
and then
Well,
this is the big thing too.
but
is
You say
after
30 cents on the dollar, but does that,
You've got
you also include the,
policy
you know, the
meals,
reimbursed
so
care that you
this
get?
is
Is that
separate.
still
Yeah.
about 25%?
So I didn't get a chance
Yeah,
to share
so
it
it's
with
really
you, and
less than
I'm happy to do it if you don't want to run up there.
You can use
Whoever
ours every
caters
30
it,
cents on
you know, is
70.
welcome to do it themselves, but I will always take
So
as
everybody's
long as I'm
hurt.
here. If you
Wow.
don't want to go up to the North Gate, Northwest Aspen,
Not what it was, that's for
that's
sure.
where the
Absolutely right.
buffers go.
It's so surprising
So we
too.
can't get any evidence
Population
of
in this area. There'd be all sorts of demand.
less and less. So usually you'll see they'll pack a couple things. Like last time you took the sheriff tray and I was like,
You would.
he was like, I'm
We
taking
didn't have a big administrative infrastructure.
so, but yeah, and whoever, so if you want to,
Yeah.
you don't want to.
Unfortunately, I don't.
Yeah.
Hear
Absolutely.
anymore.
And then, so some
Yeah.
She's invaluable.
some people at.
Yeah.
Is when you were,
Yeah, still
So, so that's
yeah. So she's there working part time. Still, so somebody's home with the kids and
yeah.
you know, ours is.
Well, the kids can be alone.
so yeah, but it's just good to be around.
So you're commuting on the pick on the day?
Yeah.
I have a 42-person lunch. I have to take it home. 42 day first and last.
That's a
And
pain
medical
also.
designation or office staff, I have to categorize them as like each individual. I don't do lunches lunch. Yeah, so it will.
Yeah.
So that you have to forget to save it as a group.
Yeah,
You
thanks.
still have to manually add.
But I mean, something looking somewhere eventually,
Fortunately, I just
So that's why I figured out the
every company.
yeah,
Whatever. Super strict.
like we had.
I mean, occasionally I look, but it seems more bench background.
Literally just, it was on debate, like, the sun was there, like, 10 shires
something in there.
So what's a good evening that you guys have over? Dinner or coffee or something or whatever?
We make it happen. Believe me. So I mean, I guess realistically.
What time do you get back home?